So I know there's a lot, but I'm just gonna hit some of the highlights, and then you guys can use the rest of it as a resource. So the main thing that you need to understand when we discuss DKA and HHNS, the big factor in those is insulin. So with our DKA, which diabetic ketoacidosis, I suppose I should quit using abbreviations and just assume you guys know what they all stand for. Diabetic ketoacidosis, DKA, and HHNS, hyperglycemic hyperosmolar non-ketotic syndrome. So in the names themselves, they talk about whether there's acidosis or there's not acidosis. Diabetic ketoacidosis, ketoacidosis, and then HHNS, non-ketotic syndrome. So your DKA is a state of acidosis. Your HHNS is not. And the main difference between those two is insulin. Insulin is the primary ingredient to help prevent acidosis. So we know that insulin does a lot of things. It transports, metabolizes glucose for energy, stimulates the storage of glucose in the liver and muscle as glycogen, signals the liver to stop the release of glucose, enhances storage of dietary fat in adipose tissue, accelerates transport of the amino acids into cells, and inhibits the breakdown of stored glucose, protein, and fat, and stimulates the transport of glucose into resting cells where it is burned for energy. So right there is the big driving factor that stimulates whether or not the patient is going to go into DKA or HHNS. If they have insulin, they can push that glucose into the cells, and the glucose is what's used in the cells to be burned for energy. If there's no insulin, glucose can't go into the cells. So that glucose just stays in the system and obviously causes hyperglycemia in our blood. And now the cells don't have glucose to use for energy. So they're not burning the glucose. So instead they start using fat. They use fat for their fuel instead. And then when fat is broken down, it turns into ketones, which is what causes our acidosis. So if a patient does not have insulin and cannot push that glucose into the cells to be used for burned energy, it's going to burn fat instead. And then that fat breaks down into our acidosis. So as I already mentioned, in the absence of insulin, the glucose can't enter the cells. It stays in the blood, causes hyperglycemia. It also causes the blood osmolality to be increased. And then that increase in the osmolality is what stimulates our thirst centers. So that's where we get those polys, polydipsia, polyphagia, polyuria. So we know that those are big signs and symptoms of diabetes in general. Just hyperglycemia is our 3 Ps. But now we're going to take it one step further. Now we have that acidosis. So when you think of the difference between your type 1 and your type 2, which type doesn't make any insulin?
Type 1.
Yeah, your type 1. So if your type 1 diabetics aren't making insulin, then they cannot, then they have that cycle of not being able to have the glucose in the cells, and then those cells are using the fat for burning that fat and breaking it down into ketones, causing that acidosis. So when you look at your differences between your DKA and your HHNS, your DKA patients are more commonly your type 1 diabetics, because there's no insulin that is acting as that buffering system to prevent the acidosis. But then when you look at your HHNS is non-ketotic, so they don't have that state of acidosis because they are making just enough insulin that the cells are able to use some glucose to burn that energy. So when you look at your HHNS, it tends to be more of your type 2 diabetics because they at least are making some insulin. They're making enough that is preventing that acidosis from occurring. So generally speaking, now again, this is textbook, this is what we're gonna go by, NCLEX thoughts, but in practice, will you see some type 2 diabetics go into DKA? Absolutely. Some have been diabetic long enough that they are just so resistant that they still go into that state of acidosis and go into DKA. But generally speaking, your type 1s tend to be your DKA and your type 2 tends to be your HHNS. So it's really important to just have this basis understanding with your general diabetes to understand these complications more in depth. Then we have our insulin types. So again, there's a handout there when we're discussing our diabetes in general. You need to bring this back to the forefront. So making sure you know which ones are your rapid, short, intermediate, long acting, and the different considerations that we need to know about insulin injections or insulin in general. So what are some things just that you need to be aware of, either your different types of insulin or when we're administering insulin? What are some of those things that you need to remember or make sure you're doing for your patients?
Glucose checks before we give them, and making sure if needed, like food's available, we give it with food, or after food or before food.
Right. Which one's the most important to give if they have their meal?
The fast acting?
Yeah, your more rapid acting ones. You want to make sure that they have their meals, or at least they're getting something to eat when you're giving those rapid acting insulins, because they're rapid acting. They're gonna bring their blood sugar down quickly if you don't give them anything with it.
And am I remembering this right, that when you're giving insulin, is insulin one of those ones where you have to have another nurse verify it?
Mm-hmm.
Okay.
Yep, insulin you're supposed to have, you're supposed to double check with two nurses. And how about our long acting? What are some considerations with our long acting insulins?
I have a really quick question about the fast acting. Just something I have noticed in clinic a lot with like other nurses and patients, I have seen a lot of Humalog given without food present, or like the food's not there. I don't know if that's just kind of like bad common practice sometimes. Confuses me. I'm like, wait a second, they don't have food right here. I can't give it.
Yeah. Yes and no. Guilty. So if you're 9 times out of 10, especially with the sliding scale insulin, depending on what their blood sugar is, you might only be giving 1 or 2 units, and is that going to like drop their blood glucose? Now, if they are super sensitive, that is one thing. If they're very sensitive, because some people are very sensitive to insulin, but generally they're not going to bottom out within 20 minutes, if they've got their meal ordered, or, that the meal trays start coming around at 8:30 and it's 8:15. Generally speaking, 1 or 2 insulins, yes, you will see nurses just go ahead and give that 1 or 2 units, and with anticipation that their food is coming, and that 1 or 2 units is not going to bottom them out. But however, some people do take like 10 units with every meal. That's a little bit more important, that, if you're giving some of those bigger doses of those short acting insulins, then you do really want to make sure, if their meal tray is not there, at least having a snack to make sure that they have something on board, so that way they don't bottom out. So it varies in practice, but again, let's think like an NCLEX. And generally speaking, you should not be giving those rapid and short acting unless their food is there and they're like literally getting ready to eat or something. So yeah, good question. I know it's so hard to do as I say, not as I do type thing. But yeah. But yes. So with our long acting then, what are some considerations that we need to know about our long acting?
I feel like I want to say you never mix insulin glargine with anything.
Mm-hmm. Right.
I'm digging way back in my mental vault.
I know, that's why I have these review things, because it all comes full circle. So yeah, your long acting you shouldn't mix with other insulins. That is one thing. What's something else?
And you always draw up cloudy before clear, so right?
Other way around.
clear before cloudy. I always get those screwed up, but
clear before cloudy, but your cloudy is more of your intermediate, but still we don't mix anything with our long acting. But yes, clear before cloudy. So we always want to draw up that clear insulin and then draw up our cloudy insulin in the same syringe, and then, you know, roll it to kind of mix it that way. But, you know, and I haven't given cloudy in a very long time. I cannot remember the last time I gave some. It's been a very long time, but still, clear before cloudy. But your Lantus, we don't mix with anything. And then one other thing, what's something else when you think about your long-acting insulins? If their blood sugar, let's say they're due for their Lantus insulin or the Gargulin insulin, Glargine, whatever, their long-acting insulin at 9 o'clock at night, and because a lot of times they do it at nighttime, and their blood sugar is 65. What are we gonna do?
We don't give it to them.
I thought they were supposed to have a snack with it.
Yeah.
Or a carb of some sort.
Right, yes. So we do still generally give it. Now, if they have a history of bottoming out through the night with it, then that's a different story. Might need to get some clarification from the physician to either decrease their dose or hold it for that night. But generally, if their blood sugar is even on a little bit of the low side, you know, 65 is a little on the low, 70 to 105 is our normal. So in case you have, because there was one handout that said like 120 was the like higher end of it, but it should just be 105, 70 to 105. So even if they're on that lower end, 65, you know, a little lower than our normal, we don't want to hold the long-acting insulin because it doesn't have a peak. It's not going to bottom their sugar out right then. It's going to last over that 24 hours to maintain their blood sugar. So they definitely need a snack, and just again making sure they don't have a history of bottoming out like in the early morning or something. But generally speaking, they still should have their long-acting insulin. We just need to make sure they have a snack with it. Perfect example.
So you can give the snack and the insulin at the same time, like you don't have to have a lag time between them?
No, no.
Okay.
So that way, yeah, like a protein. A protein is the big thing at night, the bedtime snack. So that way they have something that lasts. But yeah, we had a prime example of it this week in clinical. We had a patient who got their Lantus insulin held the night before, and I can't remember the exact reason why, but they didn't give it for whatever reason, the night shift nurse. And then that morning when we checked her blood sugar, it was 335. So it's like definitely needed her long-acting insulin. So those are important that we still give them as directed. Okay, so then, and then the rest, you know, specific time, you know, the onset, peak, and duration. I mean, you're not going to be asked those specific numbers, but just knowing which ones are your short, long, intermediate, those type of things. So that way, if you have to answer a question that says patient is symptomatic at this time of day or whatever, knowing what insulin was likely the culprit type of thing. I'm not gonna go through all this stuff. Let me skip through classification. So type 1, type 2, gestational, we will not talk about in this class at all. And then diabetes insipidus is neuro. It's actually not diabetes related at all, but we will discuss that when we talk about neuro stuff. I'm going through this. Trying to think, clicking through so that way it refreshes my memory on, oh, there's the slide. So fasting blood glucose of 105 or more then would indicate, you know, can indicate diabetes. Your random glucose exceeding 200. And then our biggest indicator as far as with diagnosing diabetes generally tends to be our hemoglobin A1C, or glycosylated hemoglobin, and it should be between 4 and 6%. So, you know, we know that different illnesses, diseases, stuff like that can increase our blood glucose levels. So if a patient's sick or stressed and that type of thing. So some of those random checks of possibly being high, or if they're on steroids for like a, you know, COPD exacerbation, something like that, can increase our blood glucose levels. So those individual instances where they reach over those doesn't necessarily mean they're diabetic, but our A1C definitely is a bigger indicator. So if they're in the hospital for a week and their blood sugars have been over 105 fasting, or have had a few random ones over 200, but then their A1C is 5, they are within a normal range. Our hemoglobin A1C is a trend over about 3 months. So it gives like an average of where their glucose levels have been running. So a normal non-diabetic should be between 4 to 6%. So if their numbers are reaching over that 6%, then that can indicate that, you know, pre-diabetic or starting to go into diabetes. But then if they're over 8%, that's definitely indicates either A, they're a new diabetic and didn't know it, and so their sugars have been really high over the last few months, or B, did I say 1 and then B, or did I say, anyway, anyway, if they're over 8, that could indicate that they're just non-compliant. If they're already diagnosed diabetic, then if they're over 8, they've definitely been non-compliant. And then we have our gerontological considerations, age-related elevation of blood glucose as well. But our A1C is really a definitive factor in helping diagnose diabetes and helping diagnose whether or not they're compliant or not with their blood sugar levels. All right, so now we are going to discuss our oral anti-diabetics. I'm going through until we get there. Wait, did I just go? No. Oh, sick day rules. That's another important thing that you guys want to refresh on. As far as education, we know education is always important, especially with diabetes and management, diet selections, those type of things. But their sick day rules are important. You know, what do they need to do if they're sick? You know, they should still continue taking their insulin, their diabetic pills, eat foods they can tolerate, lots of fluids, sick day meal planning guidelines, contacting doctor if they're sick for more than 24 hours, or if they're vomiting and unable to drink fluids. And they should be checking their blood glucose levels more frequently when they're sick, because if they're sick, we know that that can increase our blood glucose levels, so they could be abnormally high, which is why it's still important for them to take their insulin and their diabetic pills. But also if they have any nausea, vomiting, and they're not able to keep anything down, adversely, they could become more hypoglycemic. So those are things that they need to be monitoring their blood sugars more closely for, and then contacting the doctor if they're having any complications, you know, excessively elevated, or they're not able to keep anything down. Okay, so now we're gonna dive into our oral anti-diabetics. So our oral anti-diabetics are either work in the pancreas by increasing that insulin production, or in the liver to decrease the glucose production. And then some work in the intestines to slow that absorption of carbohydrates and those sugars in the intestine. But either way, all of our anti-diabetic agents are going to try and bring blood glucose levels down, regardless of what their mechanism of action is. And the major side effect for any of them is hypoglycemia. When we go through these slides, some of them do say that they don't cause hypoglycemia, but not that they don't, but they just have less of a risk of having those hypoglycemic side effects. So with these, I have made silly little sayings in order to remember the classification, what drugs are in that classification, and where they work, because those are all things that you need to be mindful of, especially the ones that work in the liver. Those patients need to be monitored closely for liver dysfunction, having their liver enzymes checked, knowing those signs of impaired liver function, like darkening of their urine. We know jaundice would be a little bit later of a sign if they have not been compliant with getting their liver enzymes checked. But so it's important to know where they work, and it's also important to know which ones like work in the intestines, because then we know that if it's blocking those starches and stuff, that they are not going to be as effective in bringing their blood sugars up with juices and pop and stuff like that. So anyway, so I made these sayings just to make it easier for you guys to remember where they work. So the first one we have is our sulfonylureas, which is our glipizide, glyburide, and glimepiride. So we got our 3 G meds there that end in "ide. And your sulfonylureas work in the pancreas to help increase insulin production. So the saying to remember this one is Sophia's grandma Gigi needs a ride for pancakes. I know it's silly, but it helps things stick. So Sophia is our sulfonylureas. Grandma Gigi, so we have 3 G's there, Grandma Gigi, so we have our 3 G meds, needs a ride, they all end in "ide, for pancakes, and then pancakes is our pancreas. So again, it just helps it stick. All right. Did you guys get that? You need me to say it again?
I think it's fantastic.
Okay. All right. So then we have our meglitinide analogs.
In like the things that we're going to need to know for each class, it's going to be the name of the drug, where it works, and what else?
The class, the name of the drug, and where it works. Yeah.
Oh, that was it? Okay.
Yeah. And not that like, so it might just say in the question, the patient is on repligninide. So not that it's going to ask you what class it is, but you know, just knowing that it works in the pancreas, it just like remembering these will help you know the class and where it works, and just, you know, what meds are involved with that. So that way you can break it down and makes it easier to answer the questions when you know where it works, or it might just say a meglitinide analog is given to this patient, and it doesn't specifically say the name of the med, but you know that the meglitinides work in the pancreas, because my saying here is Megan, so meglinide, reads novels, so it's that repligninide and netiglinide, periodically, and then periodically is for the pancreas. So Megan reads novels periodically. So with these ones, they do work in the pancreas, it increases insulin production, but they are rapidly absorbed and eliminated. So it's best that you need, since they are more rapid acting, that they take it 30 minutes before meals, and they shouldn't take it if they're skipping a meal. So if they're NPO or something, they should not be taking these medications. All right, then we have our biguanides. So our biguanides are metformin. So those are all the brand names that you hear for metformin, but they're all the generic form is metformin. And our biguanides reduce the glucose production in the liver. It doesn't promote as much weight gain. And these ones, what do we know in general when a patient's on metformin? What are some things that we need to take in consideration if they're on metformin?
Don't they have to stop it before like a surgery or something? Surgery?
That's surgery. But if they're having any scans with IV dye or anything done with
IV dye, that's what it is.
Yeah, so like our heart cath or CT with contrast, they should hold their metformin for 48 hours after. If it's an emergent situation, of course, they can't really hold it before, but they might have to hold it before and after, but definitely at least 48 hours after they've received any of that IV dye. Because the IV dye we know is really hard on the kidneys, and metformin can be too. So generally our patients who already have some kidney issues or kidney disease, they and liver disease should not be on metformin, because it can increase their dysfunction, their kidney or liver dysfunction. So they would likely choose something else other than metformin for those patients. But our biguanides, then the saying for that's just simply Betty, Met, Larry. Pretty simple. Betty for biguanides, Met for metformin, Larry is our liver. All right. This one, we have our alpha glucosidase inhibitors, which is our carbose and migdal. These are our starch blockers, so that slows down the absorption of carbohydrates in the small intestine. So this is one, it works in the intestine. So if a patient becomes hypoglycemic and they're on one of these starch blockers, you're not going to be able to get that hypoglycemia to be reversed very quickly with just simply giving them, you know, crackers and sugars or juices or pop or something like that, because that's what the drug does. It blocks the absorption of those things, so that way it doesn't raise their blood glucose levels. It still can and will, it just might take longer, and you might need to give bigger doses. So if they're like symptomatic and they're really hypoglycemic, you're going to need to do something a little bit more rapid acting, like an IV, you know, D50 or something like that. So that's what you need to be mindful of if they are on any of these medications, that you're not going to be able to get that hypoglycemia to reverse very quickly if you're just giving them oral stuff. So the one with this, oh, and also because since it does work in the intestines, it does tend to cause more like GI side effects, like bloating, indigestion, abdominal pain, and cramping, those type of things. So some people don't tolerate these starch blockers very well. But anyway, so this one, to remember, this one is our alpha. So alpha APES move. So APES is our carbose, move is our migdal, intensely. So that's our intestine for intensely. Alpha APES move intensely. I know. You know how long it took me to like come up with all these sayings, and they're still kind of stupid. I'm sorry, but you know, hey, they work. Okay, so now we have, I can never pronounce it. There are TZDs, or thiazolidinediones. Bonus points for anyone who can pronounce that appropriately. I don't know. But our TZDs are pioglitazone and rosglitazone, Actos and Avandia. So these ones are most effective for those with insulin resistance. It will not cause hypoglycemia when used alone. Again, that's used loosely. Anything that's an oral anti-diabetic can still lower blood sugars enough to cause hypoglycemia. But generally speaking, when it's used alone, it's less likely to cause that severe hypoglycemia. These, though, heart patients shouldn't be on it because it can cause myocardial ischemia. I'm not exactly 100% sure why, with the mechanism of action of why it does that, but our heart patients in general should not be on our TZDs. So this one then is TED, our TZDs, TED, zones out. So our medications that end in zone, a lot being for the liver, a lot. So TED zones out a lot. So TZDs are zones in the liver. Oh, it doesn't say on there the liver, but it does work in the liver to help lower blood glucose levels. All right, last one here then is our dipeptidyl peptidase inhibitors, which is our sitagliptin and saxagliptin. These help slow the inactivation of incretin hormones, which is released in the intestine. So these do work in the intestines as well, but not as a starch blocker. It lowers the potential for hypoglycemia, and there is an absence of weight gain with these specific medications. So with your dipeptidyl peptidase inhibitors, we have Pepi, likes Lipton, the meds that end in Lipton, iced tea being the intestines, or if you want to think of it as incretin hormone, whichever, either way would work. So Peppy likes Lipton iced tea. So I think that was the last of our orals. And then all these fixed ones, fixed combination ones, don't worry about that. Just in practice, it's just good to know, like if you see one of these that is a fixed combo drug, you know that some of them, you know, patients need both. They need it both to increase their insulin production and to decrease their glucose production in the liver. So some of these meds just work both ways, and you have these combination meds that are out there. And there's always new meds coming out. I swear, every time, I think at least once a month, I see a new med that I've never even heard of, not just with diabetes, but everything in general. It's like, oh, I've never even heard that med before, and I have no idea what it is. So if you see some of these and you don't recognize them, best thing is to just always look stuff up. Incretin mimetics, so that is our sub-Q that is not used with insulin, and it's not an insulin, it's an incretin mimetic, it mimics it, but don't need to concentrate really too much on those. The biggest thing I want you guys to study is our oral anti-diabetics and your insulins in general, so those most common things that we see. I think that was it for that one. Okay, so I'm going to go over briefly then the biggest differences between our DKA and our HHNS. So we're going to go over it more in detail next week, but it just seems to always be something that students often struggle with as far as keeping the difference between the two. So just real brief, I'm just going to do a little comparison table to really help you guys, I don't know, help it set in on the differences between the two. So I already talked about how the biggest reason between causing DKA or causing HHNS is that acidosis, that state of acidosis, and it's because of a lack of insulin. So again, it's normally our type 1 diabetics, and it's normally our type 2 diabetics that go into our HHNS. So I'm going to put our DKA over here. You know what, I'm going to put both in the middle, and our HHNS. Okay, so our DKA, again, it's our type 1. Now, because they are both in a hyperglycemic state, both are going to have really high blood sugar levels. And again, what type of symptoms do you see with patients who have hyperglycemia? That we already mentioned. Those three things.
Polyuria, polyphagia, polydipsia.
Yeah, so our polys. That there. And then our HHNS is our type 2. So our DKA then, the biggest difference, so with, let me go to both. Let's keep working on that one. So with the polyuria and the polydipsia, so what would be a result then? What would happen with that polyuria? What is something else that you will likely see with either one of these because of the polyuria?
Dehydration.
Yes. So both will be dehydrated. And what goes along with dehydration? What's something we need to be checking with dehydration too?
Electrolytes?
Yes. Electrolyte imbalance. Electrolyte imbalance. Particularly potassium. Potassium is really our big one. But that dehydration, so this isn't just like a little bit of, peeing or whatever. This is like excessive. They are just dumping urine as a result of that hyperglycemia. So they can go into a severe state of dehydration, and their potassium levels can be severely low. So those are going to be the two biggest things that need corrected in order to prevent life-threatening complications. So those, regardless of which type they are, dehydration and electrolyte imbalances are the biggest life-threatening factors. So then we have our acidosis then. So now we go into the biggest differences between the two. So again, we have our acidosis. What's something that you see in a patient who is really acidotic? What's like a compensatory mechanism that they do?
Too small respirations.
Yes. So those small or hyperventilate. Now it's pulling my thing way over there. All right, so yeah, they have those small respirations. They hyperventilate because they're trying to blow off some of that CO2 that can make them more acidotic. So they're trying to compensate by making them more alkalotic by blowing off some of that CO2. Good. So now HHNS doesn't have that because they're not acidotic. So they, will be normal. And there's something else too with acidosis. You may or may not know this, but they're tend to have more GI symptoms as a result of that acidosis. So they tend to have more abdominal pain, nausea, vomiting, those just GI upset type issues in general. GI, I will say symptoms. All right, and then they're both, of course, going to have hyperglycemia. Now, this isn't just a little hyperglycemia. This is like crazy high hyperglycemia, like, can have blood sugars in the 800, 900, upwards of 1200. This is like severely elevated blood glucose levels. However, the severity of what is wrong, the severity of whatever's going to make it the most life-threatening is not the high blood glucose levels. It's the effects of having the high blood glucose levels, such as the dehydration and the electrolyte imbalances. So those are the biggest life-threatening things, not the glucose levels in general. They're going to be shockingly high, but it's still not the biggest. It is the biggest problem, but it's not the immediate problem that we got to make sure to prevent. Now, of course, once we correct and make sure we get fluids on board and maybe correct electrolyte imbalances, then you definitely need to get insulin on board because it's just going to continue being a vicious cycle without correcting that insulin. But yeah, so again, your DKA is going to be your type 1s with all the acidosis type symptoms, and then your HHNS is your type 2, but they don't have those acidosis problems. So no small respirations, tend to not have those GI upset, and they are a little bit more, you tend to see them not as critical, as they don't look as critical because they don't seem as sick basically, but they still can be if their dehydration and electrolytes are out of whack significantly enough. Okay, so that's the main thing I wanted to go over today. So that way next week then we'll go into DKA and HHS more involved, and then we'll start with our renal subject.